We do have two more great speakers on the docket for today. As we did in the morning, we're going to shift from a talk really grounded in biology and statistics to one that helps us to focus on these beliefs and norms that we've been talking about throughout the day. And I would like to turn it over now to Josh Hauser from Northwestern University, who's going to be talking about fantasies, realities, and challenges along the dying trajectory. Thank you, Josh.
Thanks, Will. So my name is Josh Hauser. I'm a palliative care physician here in Chicago. I'm at Northwestern and the Jesse Brown VA Medical Center, which is in the western part of the city. I am here at the invitation of a colleague named Tammy Quest, who's a dear colleague and friend in palliative care. And so I want to credit Tammy with at least part of my title. I credit Tammy with a lot of other things in my life. So I want to talk about fantasies, realities, and challenges along the dying trajectory. And so what do I mean by that? So I think I think it was Will, I'll probably pin this on Will. When I talked to him late in the week last week, one of the things he said was, well, can you talk about how you get to hospice? So I'll talk a little about how you get to hospice. You'll see what I mean by that in a moment. I'll talk a little about who cares about this thing called palliative care and hospice, and I'm aware that you had a talk about epidemiology of end-of-life care. I'm aware you had to talk about advanced care planning. Where you had to talk about physician-assisted suicide and euthanasia. I hope this won't be redundant with that, but build on that. And then what I want to spend, I hope, most of our time on, and certainly in the give and take we have, are some challenges that I've seen along the way that I've been doing this work. And you can see them listed there. We'll go into those. So how do you get to hospice? Sometimes it's pretty straightforward. There are a lot of hospices, 6,000 or so in this country. And a lot of them have names like this, Journey Care. This is one of our local ones. We work very closely with this group. It's an amazing group. And this is just snatched from their website. Hospice is not a place, it's so much more. It happens anywhere the patient calls home from the house they grew old in, or a new place they have come to call home. And this is a picture of Dame Cicely Saunders, who's one of the founders of hospice and palliative care. This is another way you get to hospice. This is a company called Vitas, which is another hospice provider, a big national provider. We also work with them. We bring hospice to you, so you don't get to hospice at all. They come to you. Wherever you call home, a private residence, assisted living, community nursing, etc. Vitas is there. But what I want to talk about, and I want to frame this in terms of a patient whom I actually met just a couple days ago. I was at the VA seeing patients this morning. That's what I do with my clinical time. And think about how it's a little bit less direct and a little harder, perhaps a little more nuanced. So this is the man that I saw. His name is Mr. M, and he's an 87-year-old veteran who has a long history of dementia. And when I went to see him, he was sitting up in bed. He was able to open his eyes but not interact. He has a temporary feeding tube through his nose. That's a thin tube that snakes through his nose into his GI tract to give him nutrition. And he has something that I'm calling mittens, which I think is the technical term, on his hands. These are what mittens are. And does anyone know the purpose of these mittens? Right, so they're to restrain someone so they don't pull things. They're not to keep you warm. That's the other kind of mittens. And what was interesting and relevant to this sort of how you get to hospice is that his doctor, the physician calling the consult, calling me, said his daughter needs help thinking of the big picture and doing what would be humane for him. She had the idea that his daughter was pushing to do interventions that he didn't want or that were not the right thing. So I asked her, what do you mean? Well, I think hospice is what he needs, but I don't think she's ready to hear that. I don't know if she understands. So two issues, readiness, a lot in that word, and something about understanding. So a couple hours later, I met with this daughter, and of course, what did I expect? I expected kind of a hard conversation, because this is a daughter who's not ready. I said, what do you think we can do to focus, what should we focus on to help Mr. M? Not even a pause. I just met this woman. Not even a pause. So this is simple. This is like those slides. There you go, hospice. But it got a little more complicated, which is why I'm telling this story. She said she wanted to focus on comfort, but she also wanted him to be full code, which, as people in this room know, is medical speak for resuscitation. I tried to explore why that was, and actually tried to give her some data about why I thought it wasn't a good idea, but that didn't seem to help much. She wanted him to be comfortable, but she also wanted him to get a permanent feeding tube. There's also some data about that in the setting of patients with dementia. It's not very encouraging data. I also tried to explore that with her. That didn't seem to help too much. So the question is what's going on with this daughter, obviously with the patient too, but with this daughter. Is there some kind of ambivalence? Because she wanted hospice, and we all know what hospice is. Is this a lack of understanding, which is what the other physician thought? A lack of explaining, which is what I might not have done very well, or other people? Is this something about the grieving process? Something about hope? Or is it all of those things? So as I'm kind of going through the next parts of this talk, I want you to kind of think about this case as a framing piece for that. So I want to spend some time about kind of who cares about this stuff, and then I'll spend some time on some challenges. So one answer to who cares is kind of what we do as palliative care doctors and why I'm in this work, why my colleague Rodney is in this work, why other people in this room, I imagine, are part of this work. And this is what we do. We see patients alongside other doctors and practitioners at all sorts of points during illness. And there's a thing called hospice, which is sometimes towards the end, and this is a cartoon of that coming very close to the end, which is not always how it is, but this is a cartoon of that. So this is a definition of what we do, and that's part of the who cares question. The other part of who cares is what happens to patients. Again, I think you heard about epidemiology, and I don't know the details of what you heard, but this is what happens to patients. This is actually the pathway of the vast majority of patients in the world. All of us, or a significant number of us, will have this pathway. And this is how we're doing, health status, and this is time. And this might be when we're 50 or 60 or 70, and this might be, if we're lucky, when we're 100. But we'll have all these hiccups along the way. Things will get better, things will get worse. And that's how patients behave, by and large. And what we do with each of those is the subject of palliative care. Here's a slide, another who cares slide, which is the great variation in what we do and who gets different types of care. This is just one example. This is from a study about 10 years ago now that looked at how much intensive care people were getting in different regions of the country. Intensity of acute medical services provided to Medicare enrollees in the last 6 months of life. These are per capita numbers, and you can see that significant swaths of the country sit in the south, the southeast, Southern California, the northeast, and in a city called Chicago, people got a lot of intensive care. In other parts of the country, significantly less. I'm going to come back to this a little bit later. Another point about who cares is that what we do matters, makes a difference for people. I want to just present 2 quick studies about this. This is a study of families dying, or families of patients dying in ICUs. And in ICUs, in a large number of cases, I don't know the data off the top of my head, but I think it's about 50%. Tim would know better than me. There is a decision made at some point to withdraw life-sustaining therapies. And these investigators were interested in what was the impact of communication around that decision. A very simple question and an important question. And so once a decision was made to withdraw life-sustaining therapy, these patients were randomized to getting regular care or a withdrawal of support conversation plus a handout, something we call in the business a family meeting. And what was important about this study, and probably why it made an august journal like the New England Journal of Medicine, is they looked at these families 90 days later. And they found that 90 days later, after a family meeting and a handout, I mean, how many handouts do we get? You guys got some at this conference, right? The idea that that could make a difference Pretty astonishing. Fewer PTSD symptoms, and yet, look at those numbers. Post-traumatic stress disorder symptoms, symptoms of numbness, symptoms of flashbacks, symptoms of hypervigilance, 70% versus 45%. Anxiety, depression, need for psychotropic medications. So the lessons of this, and this is important sort of personally for me because I'm a hospital-based doctor. I see patients largely sort of episodes in the hospital, is that a pretty basic communication intervention can actually make significant difference for families. Now, it's not a cure-all, not by a long shot. It's obviously not a cure for the patient. These patients are dying. It's not a cure for the families either. But a discrete intervention actually can make a difference. And then the last study in the Who Cares, and then we'll get to our challenges, is a study from Massachusetts General Hospital now that's 7 years old, it turns out, where every patient receiving outpatient therapy for metastatic lung cancer, which is a lethal disease, half of them got palliative care, half of them got normal care. They looked at depression, quality of life, and survival. And what was unsurprising about this study is that it made a difference in terms of measurements of depression, anxiety, and then another measure of depression. What was unusual and unexpected about this study is that palliative care conferred a survival benefit of 2 to 3 months for these patients. What's going on there? Why on earth would palliative care, this care that's focused on comfort and quality of life and dignity and support for the family, give a survival benefit? They found that as compared with patients receiving standard care, patients receiving early palliative care even had less aggressive care. So there was something about aggressive care, which again is a term of art, highly interventional care, which seemed to carry some toxicity, unfortunately. Maybe there was something about these palliative care doctors just as another set of eyes and ears for this patient. And I always think of the example of a patient in this study, and this isn't a real patient, but this is a made-up patient that I think of in this study who has, again, metastatic lung cancer, which is a highly lethal illness, and gets something called a urinary tract infection. And early on in the course of a urinary tract infection, it's highly treatable. And so if the palliative care team happened to be seeing the patient that day, let's say, they might have noticed that. Later in the course of a urinary tract infection, that leads to something called sepsis, which is a lot less treatable. So it may have been something as simple as that. There's another set of eyes and ears. But patients in palliative care in this study had longer survival, which is an important and significant finding and why this study got a lot of press. So I hope I've given you some examples of sort of why I care about this, and I think why a lot of other people care about this. And this is what I want to spend the rest of our time on, which is some of the challenges. This is sort of the fantasies, realities. I can't remember what else I added to Tammy's title. Fantasies, realities, and other parts of dying in palliative care. So one is caring versus curing. And this actually is still on their website, it turns out. I did my homework and I checked. This is the National Hospice and Palliative Care Organization, which is one of the professional organizations for hospice and palliative care practitioners like me. NHPCO are the initials. And they talk about hospice focuses on caring, not curing. And I have trouble figuring out some of those differences. And I've been doing this for a while. I've been doing this work so long, in fact, when I started doing this work, people used to make jokes to me about being like Doogie Hauser, which for those of you who know, 80s and 90s TV was a TV show. And just about 6 months ago, someone told me that I could be Doogie Hauser's father. So that was a little sobering. I wasn't sure what that meant. But anyway, so I've been doing this for a while, and I still have trouble with these distinctions. What is sort of more a comfort thing, and what is a more life-prolonging aggressive thing, and what are both? And it turns out that the more advances we have in therapies, the more we have things that do both. And so it's not a very meaningful distinction for either practitioners of all sorts, nurses, doctors, social workers, chaplains, and it's not that meaningful for families. Families say they want help. they want someone to feel better. Sometimes they want someone to live longer. They don't use this language. So these are examples of things that are both comfort-oriented and may also be curing or life-prolonging oriented, and also may be ambiguous. And this is why palliative care, and again, you saw this slide earlier, sort of says, let's try to do things alongside and not, understand this line, but also realize it's kind of blurry. Second challenge is about winning. I've heard of hospice as where you go when everything else hasn't worked, like you throw in the towel. Throwing in the towel is a sports metaphor about winning, as you know. And this is a while ago, a husband I met. I hear things like this a lot still. Mickey Kaus is a journalist, and he wrote an article a while ago, which I still think about, called Looking for Mr. Good Death. Does anyone remember the movie Looking for Mr. Goodbar? Okay, so this is a play on that. Mr. Kaus's article, Looking for Mr. Good Death, was a response to an article in the New York Times about palliative care. Some people in this room might remember this article or articles like this. It was an article talking about this wonderful new specialty of palliative care. And it was really nice for me to read because I was just becoming a palliative care physician at that time. So it was very inspiring. And then I came across Mickey Kaus's article, and he had sort of 10 reactions to this article. And one of them was about winning and losing. This was number 3. The culture of medicine needs to be changed, suggested the earlier Times report. Quote, too often death is viewed as a failure. I sort of like having a medical culture that views death as a failure. It's better than the alternative. Now that's kind of tongue-in-cheek, right? I don't want to make too big a deal, but it actually gets at kind of an important point, that this is often a second choice for people. And they're not necessarily happy to see Rodney or me or other people on our team. Now that doesn't mean I won't try to help them as much as I can, and all of us will. But this is a kind of a pretty serious reaction, and one that patients and families might have. This is what I thought Tammy was talking about when she said fantasies. This is an article about another fantasy, which is in the media. And these investigators looked at TV shows, and they got a New England Journal paper out of that. That's pretty cool for a doctor.
FYI, this is my cadaver partner in medical school.
There we go. Thank you. So Dr. Diem and I think Dr. Lantos, John Lantos, who's a friend and a mentor of mine in medical ethics, was also on this paper. They had kind of a neat task where they watched all these shows. It was interesting hearing Dr. West a moment ago about sort of the longevity of companies. The mortality of these shows is what? 100%. I think they're all gone, right? So I don't know what the average length of life of shows is, but they looked at all the episodes of CPR in these shows, and they found that 75% and 67% of patients survived the immediate arrest, and some survived to discharge. That's sort of hard to tell in an hour-long show, but that was kind of what they found. Now, again, the reason I say fantasy is because the question is, how does this compare to reality, right? And here's another version of reality. This is survival at O'Hare Airport. This is actually Midway, so this is both O'Hare and Midway. And this is a study that looked, when this is when automated external defibrillators were first becoming an important thing. They wanted to see how well they worked. So these are diagrams of O'Hare and Midway and where the AEDs are, and they looked at how people did who had a cardiac arrest. So cardiac arrest on TV, cardiac arrest at O'Hare. What's the survival at O'Hare Airport from cardiac arrest? Anyone have a guess? There are a lot of AEDs, so that's good. Quick time to rescue. Okay. What other factors might influence survival? Yeah, so someone does it right. So the AED program is good and people listen to the instructions. So that was happening. What else? Most important factor around survival? Yeah, so who are the people at O'Hare Airport?
People who are traveling.
Right, they're people like us. Like a lot of you guys at the end of today maybe, or last night. and they are healthy. They are what we call vertical, okay, which is in contrast to horizontal, right? Seriously, I mean, I'm being a little bit cute with it, but so they are healthy people, so therefore that presages a better survival. So they actually did almost as well as people on TV, which is impressive, and that's kind of an important thing to know. So there are certain populations that do very well, such as healthy travelers, like all of us. Now, what's hard, of course, is when you're in the hospital, which is where I spend a lot of my time clinically seeing patients, things aren't as good. And these are a lot of series of patients in acute care hospitals and long-term care hospitals, et cetera. And the survival is between 3 and 23%. Okay, so that's different than 61%, and that's different than 75%. 400,000 patients in Medicare, in-hospital CPR, 18%. This is probably the most extensive study of this. Now, there's another cultural thing that goes on that just happened to me 2 days ago, which is sort of how we understand these numbers and how we even process them and deal with them. So I was in the ICU for a weekly meeting that we have. The palliative care team rounds with the ICU team. And I was hearing about a 47-year-old who was admitted for an amputation. He was actually pretty healthy, and he suffered what's called a PEA, or pulseless electrical activity arrest, and is intubated. And I asked the team, I said, what is his mortality? Because he's not an O'Hare guy. He's not an actor. But he was pretty healthy before this happened. And what's interesting is what they said. There were a lot of nurses. There were physical therapists, respiratory therapists, social workers, and a chaplain. There was a doctor or two at the meeting, including me. But everybody said, actually I was interested in the non-doctors, as you can see from my slide. They said, I don't know, ask the doctor. What is it about the doctor? Because what was interesting about this is I said, most of you have more experience than me. And certainly more experience than some of the younger doctors. So there's some hesitance as practitioners to even talk about the odds of winning. The answer, by the way, is this is another study of cardiac arrest. When you have an initial rhythm, we call it, of ventricular fibrillation or ventricular tachycardia, you have a higher chance of survival. You can see that there. When you have an initial rhythm or lack of rhythm, called asystole or PEA, which is what this gentleman had, you have a much lower survival. So that's a pretty bad arrest to have. That's what the answer is. But what I was interested in was why no one wanted to discuss it with me. That brings me to the next sort of challenge that I want to spend a little time on, which is about prognosticating and predicting. And Nicholas Christakis, and this is just one reference, this is Dr. Christakis' book from now a while ago, where he basically did a sociology of prognosis, mostly with physicians. And he found that physicians were generally overly optimistic. The longer that you've known the patient, the more optimistic you tend to be. And there was a significant amount of ambivalence that physicians had in even doing even prognosticating. That they felt it's not their role, they felt they might sort of be a self-fulfilling prophecy is what Nicholas called it. And as a result, there's a lot of hesitance to prognosticate. And Tony Back, who's a colleague, a palliative care physician and an oncologist, talks about this. He said, avoidance is based on reasonable concerns. First, physicians realize that they are often inaccurate when predicting survival for an individual. Second, physicians worry that discussing survival communicates a subtle psychological message that a patient will die at a given time. Third, physicians find that some patients do not want prognostic information. And finally, physicians find that bad news often causes patient distress. So these are some of the things that inhibit physicians. And Tony and others recommend a very simple task, which is saying some patients want to know about their longevity, their life expectancy, their prognosis, depending on who your patient is and their education level or their health literacy. Is that something that would be helpful to you? That's an asking permission model of communication. Now, some people we can't predict. This is sudden death. Those are people, unfortunately, like any of us, who have a sudden event. But these are the people that we sort of try to predict. But even these people, they have ups and downs. This is, again, the course of chronic illness in this country. And this isn't just a theoretical course. This is work by, I apologize, I left off the reference. This is work by Lunny and colleagues where they actually looked at ADL dependence, activities of daily living dependence, for people with a variety of conditions. People with cancer sort of are relatively high functional status and then have a dip in their trajectory. People with organ failure, which includes heart failure and COPD or chronic obstructive pulmonary disease, frailty, and sort of other dementia syndromes have more of a stuttering course. That makes it hard to predict for any of us. Okay, last two challenges, and then we can open it up a little bit more. So one is the readmission paradox, and one is something about teamwork that I want to talk about. So there are a couple articles of faith in medicine these days that people in this room know. One is that readmissions are bad, and the other is that teams are good. And as you might imagine, I don't think either of those are quite capture it. This is readmissions. This is from AHRQ, and this is a number of years ago now, but associated with $41.3 billion in hospital costs. And that is bad, by the way. That's a lot of money. And if it's not being spent in the right way, that isn't a good thing. Medicare has programs to try to reduce readmissions and penalties if you don't. So this is a significant motivator for hospitals. And this is same map that you saw before. This is the United States. Same pattern, interestingly enough, that you saw before around the epidemiology of end-of-life care. This is from Dr. Wenberg and his colleagues from the Dartmouth Atlas. And these are about regional variations in 30-day readmission rates. And it turns out the darker it is, the more readmissions you have. Now, what are the common factors for all the dark areas? Are they really sick patients, or is there something else? Access and beds. So it turns out the number of beds you have, this is the lesson of the Dartmouth Atlas, or my simplification of the lesson, is that the more beds you have, what will happen? The more you'll use them. And that's not because people are nasty and craven and all that kind of stuff, but that's just, there are economists in this room who are more sophisticated than me probably about this, but that's just, I suppose, how markets work. You have beds, you will fill them. And so that's what happens with readmissions. And again, you can see it's the same Southern California, the South, Southeast, the Northeast. Same map. It's amazing. Now here's a patient's view. I started with a patient. I started with Mr. M. Here's another patient, Mr. T. And this is what sort of illustrates the paradox for me. He has COPD, and he has been admitted 7 times in the last year. We have a clinic at the VA that focuses on these patients to try to reduce their hospital use, to try to help them with medication adherence, social support, check on them, etc. I mean, all these things that are good. I wouldn't change them. But when it comes time to talk about his values and preferences, this is like my wheelhouse. This is palliative care, what I love to do. I wondered if each of these readmissions helped him. And he said, it saved my life the last time. Why wouldn't I want to? Think about that. We look at 7 admissions in a year as a bad thing. And he says, what's the alternative? Okay, that's a challenge. So I did my homework, and I did a Google search. I have a son who is a sophomore in high school now, and when he talks about research, what he means is doing a Google search. It's really interesting. So I suppose he taught me something. And so I behaved like him recently. And these are the images that come up when you look about teamwork on Google. It's kind of fun. Here's what I want to talk about, which is kind of a more microscopic view and a story about teams and why they're so hard. And again, the article of faith was teams are good. And part of the reason I do palliative care is because I get to spend time with a great team of people. But teams are really hard. It's hard to be on a team and hang out with people and be productive. 55-year-old with diabetes, congestive heart failure, seizures, and anoxic encephalopathy is about to be extubated. Highly intensive care is going to be withdrawn on this patient. The palliative care service is called to see her and her family. Their decision to extubate her is consistent with her wishes and multiple discussions they'd had together in the past. Good advanced care planning. Okay? Over that morning and the day earlier, several nurses had also discussed this with them. Their primary care physician had discussed this with them, and the intensivist had discussed this with them. And now the palliative care doctor was discussing this with them. So how many discussions? Yeah, it could be too many. I have this like bell curve of like discussions, right? Intensity of talking. So I think the answer is several plus 1 plus 2 plus 3 plus 4. So 7-ish, which for those of you who've had conversations like this can be kind of overwhelming. So we did a lot of good discussing, I hope. And then when it came time to actually do this thing called extubate the patient, the pulmonary fellow asked to go in with the nurse to perform the, pardon that typo, the extubation. The nurse looks at him and shrugs her shoulders. As he walks into the patient room, the nurse looks down the hall, catches the eye of her manager, and coincidentally a palliative care doctor named Hauser, who was sitting at the nurse's station, and silently mouths some words to her. I'm not putting in the words that she mouthed, but I could recognize those words. They weren't nice words, as I would say to my children who were younger at the time. And they both went in to extubate the patient. So despite good communication, or maybe too much communication, maybe that's part of the problem, shared decision-making, advanced care planning, there was a conflict. Something went wrong at the end. So I always like to think, perhaps as a doctor, around differential diagnoses. So maybe that nurse wasn't informed. It was other nurses who did. Maybe that nurse disagreed with the decision. Maybe the nurse thought the fellow was a jerk. Maybe he was. I don't know. The last time they extubated, sorry about that, a patient together, it did not go well. The reason I bring this up is that there are a lot of macro things that did go well in this interaction, and then the micro version of sort of the team role thing fell apart. And I think that actually happens a lot. It's an important topic because, again, if we do procedures, and I think we do procedures in palliative care, I think communication is a procedure. This is actually a technical procedure. It's not that hard a technical procedure. For those of you who have seen what happens when you take someone off a ventilator, it has like the highest ratio of psychologically hard to technically hard. I.e., it's psychologically extremely hard and technically very easy. And because of that, you need to make sure you're doing a good job. So I won't talk about management because that's a harder one. But those are some of the things that can go wrong. So let me summarize what I've wanted to do in the last 40 minutes or so, is talk a little bit about a path to hospice that started out simple and then was a little bit more nuanced and ambivalent. That was Mr. M. I've given you some data about how end-of-life care is distributed, about how communication makes a difference, and how palliative care makes a difference to answer the who cares question. And then we've spent the last bit of time on some of the challenges along the way. So I want to close there and open it up for any questions, comments, or reflections. Thank you, guys.